We'll start off with Dr. Moorehead giving a little of the history on the background of what your government has in store for you.
Thank you, Dr. Dorrity. First, let me ask if you are familiar with the National Information Center. The address is Post Office Box 21, Springfield, Massachusetts. The National Information Center, and I will read what is the National Information Center, is an informal association of individuals involved in doing research on fascism and the right wing. We maintain files, subscribe to publications, occasionally publish reports, and infiltrate right-wing groups. NIC is not affiliated with any political organization and is non-sectarian. As a means of support of our work, we make available pamphlets, books, tapes, films, and so forth listed in the associated material. And my apology is because in Mississippi, the listing places me second on the list instead of first. Now to the subject matter at hand. There has been a long-time relationship between medicine and government, not only in America, but in all the countries of the earth. But briefly in America, it began in the 1600s when laws were passed to care for the indigent sick and laws on quarantine. And the yellow fever epidemic forced the bill in Congress on quarantine. And in 1813, a law was passed on the efficacy of smallpox vaccine and made it available on a free basis to all. In 1847, 250 years later, AMA was founded. And here we had the first medical organization to deal with government on health matters, such as the Federal Department of Health, legislation on vital statistics, state licensing, state boards of health, and others. In January 1884 came Bismarck's compulsory sickness scheme in Germany, and it started a new era. Actually, it was a new age in the history of welfareism. Bismarck's great discovery consisted of a device in making political capital out of poverty and human suffering. Ever since Bismarck, great dictators and little demagogues compete with one another with the humanitarians in courting the favor of the ailing, the lame, the blind, the underprivileged, and the aged. In 1888, compulsory social insurance was introduced into Austria. In 1891, into Hungary. In 1908, a U.S. foundation financed a study of European social and health systems, arousing liberals' interest in this country. In 1911, the National Health Insurance Act was passed in Britain. An AMA Journal editorial said at that time, "This law marks the beginning of the end of the old relationship between the patient and the physician." In 1916, a model health insurance bill was proposed by the American Association of Labor Legislation. The cost of it was to be borne by employee, employer, and state. The participation was to be compulsory. The carrier was mutual association supervised by the state. There was no federal involvement at this time in the proposal. Now, AMA took a favorable look at this bill, as actually they lent counsel to the production of the bill. AMA at this time, back in 1916, feared some form of compulsory health insurance was in the offing, backed by the government. In 1917, the Central Medical Sanitary Council was established in Russia. It was designed to bring medical care to the entire population. And in 1918, Lenin signed a decree creating the Commissariat of Health. And because of all types of pressures applied to the physicians had only two choices. One was to join up or starve. In 1934, Wilbur Cohen era started in this country. And Wilbur Cohen had just two things in mind. One was how to get more power for Wilbur Cohen, and the second was how to move America ever nearer to fully socialized medicine. Perhaps the most controversial of Cohen's prophecies involved the guaranteed income. In January 1935, a second model bill calling for compulsory health insurance was proposed. In August 1935, the Social Security law under Roosevelt was passed. In 1938, socialized medicine in New Zealand was passed, and in less than a decade, the tax for it had risen to 7.5%. In 1939, Senator Robert Wagner proposed the National Health Act of 1939, contained provision for compulsory health insurance. And the Murray-Wagner-Dingle bills in 1943, 45, 47, and 49 were all submitted, but they were turned down. The International Labor Organization wrote these bills. In 1946, the Hill-Burton bill became law in August. In 1948, the National Health Service started in the United Kingdom, and the health care services in the United Kingdom then was financed by a compulsory tax controlled by the government. This, incidentally, was the largest HMO, health maintenance organization in the world, one of the largest businesses in the United Kingdom, and it's the 10th largest business in the world. It employed over 400,000 people. It cost 5% of the gross national product, 3,000 million pounds, in 1970. In 1955, January the 1st, the compulsory health scheme for medical care came into force in Sweden. At this time, 70% of the entire population of Sweden was covered by voluntary sickness insurance. In December 1953, the National Health Act in Australia. In 1956, the Medicare Act for dependents of the members of the armed services became law. In 1957, Congressman Foran, Democrat of Rhode Island, introduced a bill providing hospital and medical care for the aged through Social Security. And the stage now was set for the final Medicare bill. The Foran bill did not pass at that time. In September 1960, the Kerr-Mills bill became law. This was the first major government medical program. In 1961, the King-Anderson bill was introduced, called for financing through the Social Security mechanism. In 1963, President Kennedy was assassinated, and Lyndon Johnson, beholden to labor and liberal forces, became president. In 1964, well, it was just a little before this, the AMA now admits that they began to accept the inevitability of the total socialized medicine for the United States. At the AMA meeting in New Orleans in 1971, Russell Roth said the AMA has been working on Medi-Credit concept for 12 years. In 1964, elder care was an AMA proposal, and it was relatively comprehensive, but it excluded Social Security financing. This set the stage for July 1965, when on the 30th, Medicare became law. And it satisfied the comprehensiveness of elder care, which is an AMA proposal, but the law settled solidly on Social Security financing. Wilbur Coyne was the principal architect for the Medicare law. Since 1965, we've had regional medical programs, heart, stroke, cancer program, experimental programs financed by the federal grants, such as the Tufts Medical School from Massachusetts and Mississippi in the Mount Bayou area. And then we had health maintenance organizations. We've recently had the $9 million federal health care experiment. This experiment developed by the RAND Corporation for the Office of Economic Opportunity to involve 400 families in Dayton, Ohio. The plan set forth by RAND calls for an expenditure of nearly $7 million of the $9 million for administration only. Now, the certification of need laws have been projected. And incidentally, in the certification of need laws, I have in the Archives of Surgery, volume 106, June 1973, Massachusetts Joseph L. Dorsey gives a nice article. He says, many of our readers have felt the impact of certification of need laws. They have impinged on current and proposed plans for construction of new surgical facilities. Dr. Dorsey is Director of Medical Planning for the Harvard Community Health Plan in Boston and is a member of the Massachusetts Public Health Council, which is a decision-making body for certification of need determinations in Massachusetts. The term certification of need, known as CON, refers to the process through which a governmental agency reviews the proposals of healthcare provider to initiate, expand, or change facilities and services and determines whether the applicant should be granted or denied permission to carry out the proposed project. As the name suggests, the needs of society for proposed health care program constitutes a measuring stick. And I ask the question, what's wrong with a group of physicians or other individuals building a private hospital to equip it well, staff it well, operate it efficiently? Nothing. The certificate of need agencies may well say no. I don't see anything wrong with the private free enterprise system of competition. I think this can be brought out in a moment. This is a governmental program and its efforts are to stifle private competition, as the effort was shown in San Antonio, Texas, where a group was trying to build a private hospital, and the governmental agent says, no, we don't need any further help here. We've got all the beds that we can use. Well, they, for some way or other, got by and built this hospital, and they are going along mighty well. As I will bring out in a moment, private medical care costs less than government-controlled and operated medical care. And this involves your taxes. You're the ones that are going to pay for this. The most outstanding example of this is the Veterans Administration hospital care. The government cannot stand private competition. Public Law 92603 H.R. 1, Professional Standards Review Organization, the so-called Bennett Amendment, has just been passed. And under PSRO, the physician will be required to treat, that is, the Medicare and Medicaid patients, not by his own professional experience and judgment, but according to computerized norms approved by the Department of Health, Education, and Welfare. And I'm going to quote, norms designed to reflect minimal utilization of services and facilities and always the least expensive care available, unquote. This is taken from an article in Private Practice. Of course, the patient gets inferior care under these circumstances. There can be no medical progress under these circumstances. The physician may be required to pay a fine of up to $5,000 should he vary from these norms set up and approved by HEW, the computerized norms, even though the patient's care was what the physician considered best for the patient. We in AAPS believe this to be bad for the patient and the physician. This will be brought out more completely by other members of the panel. Now we'll go into further programs such as the National Health Insurance Legislation, Medicredit, which is the AMA project, and all the others, including the proposed Health Security Act supported by AFL, CIO, United Auto Workers, and Kennedy. One consistent and invariable characteristic of all compulsory sickness schemes is that once established, the abolishment altogether of a compulsory sickness scheme, even if unsatisfactory and bankrupt, is beyond imagination. It never has happened. Further, they all cost the patient more than does private medical care by way of taxes. 12% of all British taxes go for medical care. In France, the average worker pays up to, in some cases, 33% of his wages for the French system of socialized medicine. Germans pay 11% of their salaries for governmental medical care. In Sweden, the Swedes pay 20% of their taxes for socialized medical care, the highest in the world. Now, while referring to Sweden, let me read directly from a letter to the editor in the June 11, 1973 edition of the Journal of the AMA, written by Leland M. Reed, M.D., Rantoul, Illinois, in answer to an article in the previous edition of AMA Journal written by Dr. Andrews, Jr., in which he was giving the unfavorable comparison. He was giving the unfavorable comparison of the medical service in the U.S. and Sweden. Now, I'm going to read this because I think it's very important. Sweden is not one of the healthiest nations in the world. Infant survival, a minor part of the health scheme, is more a social than a medical problem. Then to compare the rate of the homogeneous little country like Sweden to a heterogeneous subcontinent like the United States is like comparing grapes to pumpkins. Compare Sweden to Utah, if you wish, their rates are about the same. Or compare the United States to Europe, our rates are rather better, but not Sweden to the United States. Swedish socialists never mention rates that are unfavorable. They have significantly more deaths in Sweden from stomach ulcers and from pneumonia than we do here. But you have to search for these figures. Andrews' economic figures are accurately quoted from the socialist sources, but they lie. Swedes actually pay out closer to 70% of their income in taxes in the $10,000 a year bracket. Swedes actually pay 15% of their income for all health matters. We pay 4.75%. This is to say that for a system that is, at best, nearly as good as ours, Swedes pay over 200% more. What a terrifying waste. He states that Swedes have more hospital beds. True, but they stay in hospitals more than twice as long. The end result is that there are less beds available in Sweden. In Stockholm alone, there is currently a waiting list of over 4,000, of which 1,800 are surgical cases. Swedes admit there is a doctor shortage, but they are correcting this. They forgot to mention that this is being done by lowering admission standards to medical schools and by shortening the medical course by 2 years. There are no good features to a socialist plan. I know. I spent 10 years in Saskatchewan under a Fabian socialist government. To claim we should adopt the good features of Swedish medical care is tantamount to saying we should adopt the good features of a bank robbery. That is, tidying up the cash drawers, getting money in circulation, and keeping the guards on their toes. It just isn't worth it. In the United States, the Department of Health, Education, and Welfare now spends more than all the profits after taxes of all the corporations in the United States. The corporate profits are $49 billion, HEW is spending $58 billion. Now look here. A study group in HEW, the Commonwealth Health Scheme, found that the average cost per medical visit are only about half as much in the private fee-for-service offices as in the neighborhood health centers or prepaid group. Now, mind you, this is not our talking about. This is HEW. The average cost in private practice is $9.59. The average cost in the U.S. neighborhood centers is $21.16. And in the prepaid group practice is between $18.07 and $19.41. And I've just quoted this from Medical Economics of June 11, 1973. Now, we've heard so much about the cost of medical care, and I want to read you a little bit. It was by one of our men, Dr. Jack Schreiber, and I'm quoting out of the American Family Practice of May 1973. Is medical care too expensive? It may be for some people, but in answering the charge, let's point out something that most people overlook. The patient can probably prevent at least half of his yearly medical expense. In 1970, according to Science Digest, the American public spent more than $2 billion on quackery, more than was spent on medical education. In that same year, according to the National Safety Council, 49 million people were injured, and 1 out of 5 of those was bed disabling. And what about the cost of other preventables? There are 60 million users of alcohol, which includes about 10 million alcoholics. The cost of this enormous problem is included when the headlines scream, medical care costs too much. What about the effects of drug abuse? In 1970, more young people died in this country from drug abuse than all the Americans killed in Vietnam in the same year. When our critics say medical care is too expensive, let's answer by asking a question. Too expensive compared to what? Certainly not too expensive compared to transportation. Last year, the average American spent almost twice as much on his car as he did on his body. Medical care too expensive? Not when compared to tobacco. $10.2 billion. Or to an alcoholic, $16.4 billion in alcoholic beverages in 1969. When added to the $36.3 billion for recreation, plus $9.7 billion for personal grooming in that year, we Americans spent $30 billion more for good times than we did on health care. The next time someone asks medical care is too expensive, at least you have the ammunition to say compared to what? Thank you very much.
Thank you, Dr. Moorehead.